Now, before moving on to the approach itself, I would like us to remind ourselves that there is one very important other contraindication to use of adenosine or dipyridamole. That is the so-called pharmacologic stress test. And what is that? That's the patient who takes theophylline. I know it's not very commonly used anymore, but just it's a theoretical knowledge to have, and there are also clinical circumstances that, for example, an asthma patient may take theophylline. What is the mechanism of action of theophylline, by the way? Theophylline is a phosphodiesterase inhibitor similar to dipyridamole, and thus by increasing levels of cyclic AMP helps bronchial dilation. So why is it contraindicated in patients who need a stress test? Why is it a contraindication for pharmacologic stress test? It's especially a contraindication for pharmacologic stress test. That's the ones done by adenosine and or dipyridamole, because theophylline is also an antagonist of adenosine. This may sound controversial because we mentioned that adenosine itself increases cyclic adenosine monophosphate, and now we are also saying that theophylline increases cyclic adenosine monophosphate. Yes, but these are two different mechanisms of theophylline, and because the main drug used in the pharmacologic stress test is the adenosine, we don't want to use it in a patient who takes adenosine antagonist. Also, to remind ourselves that if you hear the term pharmacologic stress test, that's mainly when we use dipyridamole or adenosine compounds. And for the dobutamine, even though it's a pharmacologic stressor, it's usually referred to as the dobutamine stress echo. A couple more questions regarding the physiological philosophy, I should call it, of the stress test. What's the main idea? The main idea is augmentation of blood flow by any of these three methods of stress test is more significant in the non-stenosed vessels than stenosed vessels. So what would be identified in the area of coronary stenosis in any of these stress tests? Well, in ECG we will have the localized ST and T changes, the changes of the ischemia. In the echo we would have wall motion abnormality in the region with stenosed vessels. But most importantly, in RMPI, in radionuclide myocardial perfusion imaging, we will identify reduced radioisotope uptake in the area of stenosis. Just a brief note, the radiotracer is technetium-99. The agents used are either cistamib or tetrophosmin, if I'm not wrong. These are the two agents utilizing technetium-99 labeled materials for the radionuclide myocardial perfusion imaging. What are the two methods of radionuclide imaging used? One is a SPECT and the other is PET. For SPECT, more precisely, the perfusion is measured, while in PET, the metabolism is measured. All these tests have the resting phase and the stress phase, and then the regions of the heart are being compared in these two phases. Based on that, can you postulate three possible scenarios regarding the radiotracer uptake? Well, radiotracer uptake would remain intact or is optimal in both stress and rest phase. This condition is associated with low risk of coronary artery disease. The risk is estimated to be less than 1% annual risk. The second scenario is we have decreased radiotracer uptake only in the stress phase, but normal uptake during the rest phase. This means stress-induced stenosis, right? And so this is exactly what we are looking for to do the next step, which is angiography. The third scenario is there is decreased uptake in both resting and stress phase, and that means presence of ischemic necrotic tissue and presence of dead tissue. And because of that, we do not do angiography on that because there is no way to revive a dead tissue. So understanding of this concept is crucially important for the next step decision making. So with this background, I think we are now ready to initiate the approach to stress testing. The first question regarding the overall stress testing approach is, what is the best stressor in general? The best stress test is considered the exercise-induced stress. So we initiate with exercise ECG test. Now, we have two possibilities. The patient can exercise or cannot exercise. If the patient is able to exercise, we look at the baseline ECG. If the ECG is normal, that's no ventricular pacing or no left bundle branch block, the exercise ECG is the choice for this patient. However, if the ECG is not normal in the person who is able to exercise, we would stay with the exercise portion as the preferred stressor, as I said, is exercise. But we choose an exercise imaging test. That is either exercise echo or exercise radionuclide imaging. So that takes care of the patient who is able to exercise to reach the target heart rate. I assume by now you are familiar with the rest of the algorithm. So if the patient is not able to exercise, that means we have to use another stressor. And depending on whether or not the patient has any of the contraindications, we pick the pharmacologic vasodilator stressor or we pick dobutamine. So with this framework, then you start applying your knowledge of contraindications to different stress imaging methods as we talked so far. Always remember, our first choice of pharmacologic stress are vasodilators, that is dipyridamole or adenosine, regadenoson. And if the patient has contraindication to them, we use dobutamine. So what are exact contraindications to pharmacologic vasodilator stress testing? Well, the patient who has hypotension, logically. The patient who has bronchospasm, logically, because adenosine functions as bronchoconstrictor even though it functions as coronary dilator. Please remember this point from molecular biology. It would help understand several drug interactions with theophylline, dipyridamole, adenosine, and their possible side effects. Why is it so? It's because adenosine has a different set of receptors on the bronchial tissue as it has on coronary arteries. The A2 adenosine receptor that is present on coronary arteries increases cyclic AMP by activating adenylyl cyclase and therefore causes coronary dilation. However, on airways, we have a 1 adenosine receptor that causes smooth muscle contraction and bronchoconstriction. Put it simple, adenosine mediates coronary vasodilation and airway bronchoconstriction, and therefore the patients with bronchoconstriction should not receive adenosine or the adenosine stimulators such as dipyridamole. Remember, we mentioned that a second mechanism of action of dipyridamole, in addition to inhibiting phosphodiesterase, is to inhibit the reuptake of adenosine. And thus, put it simple, both arms of pharmacologic stress, that is dipyridamole and adenosine compounds, are contraindicated in patients who have bronchoconstriction. So far we mentioned two contraindications to the vasodilator or pharmacologic stress test: hypotension and bronchoconstrictor underlying disease. What else? Well, logically, the patients who already take any of these drugs, including the dipyridamole, would not benefit from it. And the fourth logical group are the ones who take adenosine antagonists, the methylxanthines such as theophylline. A very important other final group to commit to memory, just to memorize: patients with high degree AV block are not good candidates for pharmacologic vasodilator stress testing. So put it simple, bronchospasm, hypotension, use of theophylline, already using dipyridamole, and patients with high-grade AV block are the contraindications to pharmacologic vasodilator stress test. What are the contraindications to dobutamine? As we mentioned, once more we need to review. Most important is ventricular arrhythmias, especially any type of tachyarrhythmia, but also unstable angina, recent MI, aortic dissection, severe hypertension, and left ventricular outflow tract obstruction, such as hypertrophic obstructive cardiomyopathy. Now, do you remember aortic stenosis is a specific contraindication to which one of these tests? Well, hypertrophic obstructive cardiomyopathy or any type of left ventricular outflow tract obstruction is a contraindication to dobutamine. Always remember that exercise stress is also contraindicated by presence of aortic stenosis. You remember the high risk of syncope in patients with aortic stenosis when they exercise. So that's the reason we don't want to use stress test or dobutamine, a positive inotrope, for the patients who have left ventricular outflow tract obstruction, hypertrophic cardiomyopathy, or aortic stenosis. Once more, what patients cannot benefit from exercise as a stress? As I mentioned, the patients who are not able to reach the target heart rate, but you may also hear it in different terms, and that's the patients who are not able to reach the activity level that's defined as an equivalent to 5 METs. If you wonder what is the MET or metabolic equivalent, it is the oxygen uptake that's calculated at rest, and 1 MET is 3.5 milliliter oxygen uptake per kg. And so if the patient is able to reach at least 5 MET equivalents, that's said that the patient is capable of doing the exercise as the stress. The other criteria is the patient is able to reach the target heart rate. If not, we need to use pharmacologic stress. Once more, what are the baseline ECG findings that make ECG not valuable imaging for stress testing? Left bundle branch block, V pacing, ST or T abnormalities of more than 1 millimeter, and pre-excitation. Any of these conditions means we need to use other imaging such as echo or RMPI. In addition to ECG abnormalities, however, there are 2 other conditions in which the patient is not a good candidate for ECG and requires echo or imaging. What are those conditions other than the baseline ECG abnormalities that the patient should not use ECG? One is patient with history of prior revascularization, and the other is the patient who is taking digoxin. Again, these both could be translated into possible ECG abnormalities, but regardless, presence of prior revascularization or patient who's taking digoxin are other contraindications to use of ECG as the imaging modality. So added to the 4 previous ECG abnormalities on baseline, which are contraindications for ECG. These 6 group of patients require imaging other than ECG. So this is pretty much all you need to know for the test of choice, how to choose the best test. There are a couple additional details that I just, for the sake of completion, I would add them in case you have time to commit them to memory. Worth it. If you are asked what is the best imaging method for detection of myocardial viability, what's the best imaging modality? That's PET. Now, when stress echo is the preferred method for patients with new murmur, congestive heart failure, hypertrophic cardiomyopathy, or pericardial effusion, the preferred imaging is said to be echo. Okay, enough with the details. Let's briefly discuss the endpoints. So, for example, a patient receives a stressor, is running on treadmill. We measure certain endpoints for our test, right? So what are the endpoints? Always remember there are 3 types of endpoints. One is patient-determined endpoints, the other is provider-determined, and the other is protocol-determined endpoints. Give examples of patient-determined endpoints for stress testing. One is the patient has chest pain or has fatigue or dyspnea, or just patient doesn't feel good to continue. Put it simple, any limits from the side of the patient. Now, give examples of provider-determined endpoints of stress testing. Well, one is when the ECG endpoints are achieved. For example, we have significant ST or T changes, more than 1 millimeter. The other is if the patient demonstrates very high blood pressure values, such as systolic more than 250 or diastolic more than 120 millimeter mercury. In same way, if the patient has hypotension, shows significant ST depression or high-grade AV blocks, or shows some form of arrhythmia, especially ventricular tachycardias. But remember, any arrhythmia, as I mentioned, high-grade blocks, even ectopy, supraventricular, or ventricular tachycardias are all endpoints from the perspective of provider. And of course, logically, if the provider feels that the patient is not in a good condition to continue the test. If you have ever observed any stress testing, you would see that provider stands by the patient on the treadmill, keeps checking the patient, keeps asking if he wants to continue, etc., etc. So these are the provider-determined endpoints. And finally, what are the protocol-determined endpoints? Well, based on the protocol used, one of the most famous protocols that's used is the Bruce protocol. As we talked earlier, we have a couple endpoints that should be reached. One is the metabolic equivalent, that's at least 5. So if 5 metabolic equivalents are reached, or if the target heart rate is reached, then the protocol may just say that's enough and stop the assessment, stress testing. Now, what is the next step if the results are reported as positive, negative, high risk, etc.? Just remember, the results of stress test could be reported as positive, could be reported as negative, could be reported as high risk. I would like us to know that the positive results are the ST&T changes, or so the first scenario is when the stress test results are reported as negative. What's the next step? The next step is simply follow up and discharge the patient, considering other alternative diagnosis for the chest pain, such as esophageal, chest wall, anxiety-induced, or even biliary dysfunction. Now, the more challenging interpretation is when the results are positive. Remember that not all positive results are considered high risk or of prognostic value. You probably do not need to commit to memory what are the exact high risk findings in exercise stress testing, but you need to know that if anything is reported to be of prognostic value, that is poor prognostic factor, what is the next step? And the next step would be coronary angiography. Okay, I'm again not saying for any positive, for anything other than the high risk features, you just refer the patients to the cardiologist. For the high risk features, the patient needs coronary angiography. Let me just give you a couple examples of these high risk features. One example, the most important one, or the most important predictor of worse outcome, they call it, is sustained ventricular tachyarrhythmias during the exercise test or during stress test. The other is even presence of PVCs to the lesser extent. The other is either the patient is not able to reach the target heart rate, even though initially predicted so, or if the patient reaches the target heart rate, but it takes him more than expected to recover from the peak heart rate. Usually it takes patients a set amount of time based on standard protocols to recover and slow down their heart rate, but some patients remain on a very rapid heart rate for a long time, longer than expected. Those are again predictors of worse outcome. So these are examples of high risk features, but there is a prerequisite for any of these findings to be significant, and that's it should be reversible. That's it should be happening only during the stress phase or the exercise phase, but they should not exist during the rest phase, because if there is a non-reversible, say, wall motion abnormality, that means scar tissue, and the patient would not benefit from any further procedures such as revascularization, etc. So 2 requirements for angiography: reversible changes and high risk features. Everything else requires cardiologic referral and is beyond our discussion here. So in summary, we have a patient with intermediate probability of coronary artery disease based on the coronary artery disease risk scores. Could be a patient with risk factors, come to an office visit, or could be a patient with non-specific chest pain discharged from the hospital, or have any other indications of stress imaging. We use our administrations, our hospitals, our clinics protocol. We pick a protocol for assessment, and the most commonly used protocol is the Bruce protocol. It has 3-minute stages in the exercise test. Each one gets more and more challenging or faster pace. Each test has predefined endpoints, either based on the patient's condition or based on the provider's determination of blood pressure, heart rate, ECG changes, etc., or based on the protocol. For example, 5 METs metabolic equivalence or the target heart rate is reached. After the endpoints are reached or the target changes that we were trying to seek are identified, we stop the exercise or stress testing. Then we use again predetermined criteria based on the protocol we use to classify the patients into low risk that will follow up for the non-cardiac causes, or positive, and positive could include high risk criteria, again based on our protocol. Again, examples are the changes in heart rate or arrhythmias or ST changes. If and only if the patient meets two requirements, one is the stress test results are reported as high risk, and two, if those are reversible changes, the next step would be cardiac catheterization or angiography, in other words. Now, we have certain criteria to determine what is the best test for each patient. If the patient is able to exercise or reach the 5-MET or target heart rate, the patient would exercise. If the patient has some baseline changes in ECG, we do not use ECG. Always remember the best test otherwise for patient who does not have any contraindication is exercise ECG. The second best test is pharmacologic, also known as vasodilator radionuclide imaging. The final test is dobutamine. Know their indications and contraindications and follow this simplified algorithm, and you are good to understand and apply whatever you need for stress testing.